If there's something more scary than being the only doctor responsible for the airway of a child who's not breathing, I sure hope I never discover what that is. Um, and so I am thrilled today, as part of our Just in Time series with RAPM, to welcome Dr. Marianne Gaucher-Hill to talk to us about pediatric rapid sequence intubation and how to manage that incredibly stressful situation. I can't think of anyone better suited to talk to us about that. Dr. Gaucher-Hill is professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine in UCLA at Harbor-UCLA Medical Center. And she's a nationally and internationally known researcher, educator, and leader in the field of emergency medical services and pediatric emergency medicine. Dr. Gaucher-Hill, thank you so much for joining us today to talk to us about this incredibly important, incredibly terrifying thing, the child not breathing who needs an endotracheal tube from you.
No, thanks for having me. It is a stressful time, I can tell you, when that scenario happens.
So let's dive into that particular scenario.
All right.
Imagine that you're not a seasoned pediatric emergency medicine doctor who's a national leader in the field, but instead a green emergency medicine doctor, fresh out of residency, working at a critical access hospital. You're the only doctor in the hospital. It's 3 a.m. and EMS calls and says they're 10 minutes out with a 2-year-old not breathing. What do you need to be doing right now?
Yeah, that's pretty scary. I think probably the first thing I'd like to say is you probably should be prepared before you even get the call. And so there's a couple things to consider. One is to have a length-based resuscitation tape, such as a Broslow tape is one example, because then with that 2-year-old, you can quickly determine weight and various sizes of equipment. And the other thing is to have several bag mask ventilation devices. I would have an infant and a pediatric bag. Certainly, those should always be available in any resuscitation bay that you have, just so that even if somebody walks in with their limp child, you're ready to go. And the next thing is just assemble your team. Take a breath, assemble your team, and get your bag mask device and start thinking about how you're going to proceed in this resuscitation. And generally, it's you always start simple and then move to the more complex.
Fantastic. Why don't you take us through that process?
Sure. First of all, relative to disclosure, the RAPM projects are supported by ASPR. And so these are my views and don't necessarily represent the official views of ASPR or the Department of Health and Human Services. All right. Now let's
I'd much
jump
rather
right
have
in.
you be doing this intubation than the federal government. I'll tell you that right now.
Yeah, I should say. But
All right. So this kid is rolled in. They're on the bed.
yeah, you want to position the head, open the airway. At this point, you want to always consider foreign body if there's a scenario that would suggest it. And certainly as you start bagging a child, if you have airway obstruction, you need to think about it. Your options are if the child's spontaneously breathing, you add 100% oxygen. You always think about what tools you have available. Either high flow nasal cannula, CPAP, BiPAP could be used to support oxygenation. But many EDs don't have that readily available, so bag mask ventilation is really your go-to. And then you have to consider as you're bagging if they're not responding, or if indeed you think you're going to need long-term support of the airway, you have to think about endotracheal intubation at that point. And then finally, what kind of backups do you have? So a take-home is you must have some contingency. And now with supraglottic devices, it is awesome. They're so easy to use, either an LMA or an iGel, and you can establish the airway and support oxygenation and ventilation. So really the key is preparation. I mentioned equipment and staff, and have that contingency plan, because that's really what's going to help you be empowered to do what you need to do. And if things go awry, you'll always have a backup. And we'll get into that in just a little bit. Next thing is tube size. For me, you've seen these various formulas for uncuffed and cuffed tubes. My feeling is forget about it. at this point. I'd do something very simple, which is the 1-5-10 rule. And what that means, 1 year, 5 years, and 10 years is 10, 20, 30 kilos is a 4, 5, 6, and you extrapolate. So a 3-year-old, 2-year-old, a 3-year-old, even a 4-year-old would be a 4.5 ET tube and 15 kilos. At least you'll be in the zone. And again, you can use a length-based resuscitation tape to really back you up. So let's just talk about blades, and it gets really confusing. The bottom line, if you use too small of a blade, it's going to be problematic. Okay, so you want to go big if you're going to go. All right. So when do you use the Miller Zero? Only if the baby you birthed the baby or the baby's birthed in front of you. Otherwise, it's a Miller 1. So again, you can remember it, Miller 1 at age 1. Miller 2, you can see the age range there. So Miller 2 after age 2, and then finally Miller 3 after or at 3rd grade. So that's a quick, dirty way to remember blade size. So you know, you got a 2-year-old, you need a 2. And you can use either a Mac or a Miller, and I generally start that at Mac 3, but if you wanted to do it at 2, you could. So then you have to think about this whole RSI thing, you know, how do you remember it? And, you know, there were the 7 this and the 7 that. I don't do any of that. So oxygenate, sedate, paralyze, and intubate, because you got to move quickly here. And the key is to try to get the pulse ox above 95% if you can. So if the patient is not in full arrest, again, you're going to be bagging them before you start the procedure to optimize it and to keep them from desatting and potentially becoming bradycardic. You want to use high flow oxygen, or if they're apneic or agonal, you're going to begin to bag them. The next thing is supporting oxygenation during the procedure itself. And when you do that, you just add a nasal cannula. You can do 1 to 2 liters per year, up to 15 liters like we do in the adults. Right? And you put the nasal cannula on, you can bag around it or add oxygen. And then once you remove the either the bag mask or the non-rebreather and you initiate RSI, they're getting passive oxygenation through this method.
So that
Now
nasal
the
cannula is
next,
staying on throughout, right? It's
yeah,
staying on during the apneic period.
absolutely. And so that's really important. And if you need to bag, you need to put a lot of pressure, or you bag them up to 95%, put the nasal cannula on as you're just prior to initiating the intubation sequence.
Great.
Now, people talk to us about sedation, and there's many, many drugs that can be used here, okay? But I like to keep it simple. My go-to are ketamine and etomidate, okay? If they're hypotensive, my suggestion is ketamine, although etomidate has really good features in terms of cardiovascular features, so you do not get hypotension with it. But in septic shock, the recommendation is to stay away from etomidate and use ketamine. So if you had to use one drug, I would use ketamine. But head injury, there's some mythology around that. Ketamine actually supports mean arterial pressure. So ketamine is a great drug, and it's also helps with bronchospasm. So ketamine, you could also, your backup could be etomidate.
Great.
Now, what about paralyze? Succinylcholine or rock? All patients can get rock. It's very unusual to have any issues with rock. It's easy to remember, 1 per kilo. And now that we have a reversal agent, it really helps. Now, succinylcholine, you notice that's kind of a high dose, but I use 2 because the kids metabolize it rapidly. Any child with any muscular dystrophy, cerebral palsy, etc., you would not use succinylcholine. So if you needed 1, I would do rock, but you need to also have Bridion available because rock lasts way longer than succinylcholine. Immediate reversal is high dose, 16 mg per kg. Otherwise, you could, if you're able to successfully bag and you can take your time a little bit, you know you can bag, even if you're unable to intubate successfully, then you could go with a smaller dose. And finally, I just want to say for our sign kids, if you can, any child with poor perfusion that needs to be intubated, try to oxygenate them and give fluids, try to fluid resuscitate them, because if you take away their adrenergic drive, they could go into cardiac arrest. And then consider early pressors post-intubation, such as push dose epi. And then finally, you got to have a backup plan. So it's generally going to be bag mask ventilation. Supraglottic airways are inexpensive. You should have it as part of your difficult airway kit. And iGel I find super easy to use, or LMA also. And then other methods are listed there for you. Hopefully you don't get to cricothyrotomy, but if you cannot bag, you can't intubate, and you cannot use supraglottic devices, it would be a consideration. And then finally, airway management is a stepwise process. I mentioned RSI. You should have a structured approach: oxygenate, sedate, paralyze, and intubate, and have your contingency plan. And here's everything we talked about. I mentioned about bag mask, but squeeze, release is a nice way to control the rate of ventilation, and you can see everything there. You're an expert at this. Take a breath. You got this. Thanks.
Fantastic. Thank you so much. And as a pediatric surgeon who has gloved up to do the cric, but never actually had to make an incision, I am so thankful for our emergency medicine colleagues who are always able to get that airway. I know it's super stressful in the moment, but there's no one better for the job. So I really appreciate your taking the time to run us through this today.
Sure. It's my pleasure. Thanks so much.